we are super excited to welcome Dr. Shraddha Patel to today's webinar. Thank you so much for taking the time to speak with us today. Dr. Patel is board certified in neurology and did her fellowship in vascular neurology. She specializes in diagnosing and managing neurological conditions in hospitalized patients with advanced training in acute stroke care and emergency neurology. She earned her undergraduate degree in microbiology and biomedicine at Clemson University. She obtained her medical degree from Windsor University and completed her neurology residency at Prisma Health Midlands. She obtained her fellowship in vascular neurology at Duke University, and outside of medicine, Dr. Patel enjoys traveling, immersing herself in different cultures, and dancing. She is also a clinical assistant professor of neurology at Wake Forest University School of Medicine. Dr. Patel, thank you so much for joining us, and we're so excited to hear from you today. Is there anything else you would like to add before we get started?
Wow, I don't think I've heard that about myself, or at least someone else talking about myself. But want to say thank you for having me. I'm happy to be part of this initiative that you all have set out, and I hope that you find it helpful and informative as we come along. But yeah, I grew up not too far from Columbia in Orangeburg, South Carolina. So I'm, I guess, a South Carolinian by heart, and went to Clemson for undergrad. So go Tigers. I'll just put that shameless little hooray in there. But yeah, I think in terms of my education, et cetera, you've already gone through that, so I won't bore you with repeating about that. So if any questions, in the meantime, we can talk about that.
Yes, and feel free, again, like we said, if anyone has questions, put them in the chat and we'll get to those in the gaps in between. But we can go ahead and get started with more of a general question. Can you share a little bit about your journey into medicine from undergrad all the way until where you are now, your fellowship and beyond that? What drew you to neurology? What makes it unique and rewarding specialty?
Yeah. So just kind of a quick recap. So I went to Clemson for undergrad. Right out of Clemson, went to medical school, which is usually, the path that you see majority of medical students take. And I went to a Caribbean medical school, so Windsor University. I chose not to take a gap year, and I know that was a question that's come up before in terms of is there a big negative stigma towards taking a gap year? And I would actually say no. I think it actually helps with both personal and professional growth development. Should you want to, increase your chances of getting into medical school in a particular state, wherever in terms of location. But so I went to Windsor, and then I did my first 2 years of med school there in St. Kitts. Then moved to Chicago for my last 2 years of rotations. And compared to, I guess, medical school here, if you are an international grad, which although I was, born and raised here on stateside, since I went to medical school out of the country, you do have to take both step 1 and step 2 before you're eligible to apply for residency. So I had a year and a half of a gap year between medical school and residency. So during that time, I was preparing for boards, but also building my CV in terms of working in the neurology sort of world. I worked as a stroke coordinator for a primary stroke center in my hometown in Orangeburg, and that certainly opened up more opportunities and I would say connections for me to move forward in terms of matching into residency and things like that. And joined Prisma, did my residency there, and then went to Duke for fellowship for a year. And I joined Atrium Health right out of fellowship for my first attending job. And I've been here for it'll be 3 years this June. So a prolonged path, but it just tells you that medicine, the path is not linear and everybody's path looks different, but ultimately you get to your goal. So does that kind of answer the question?
Yeah, for sure. Is there a reason why you specifically chose neurology and want to do this specialty?
Yeah, so when I started medical school, I think I was drawn to emergency medicine, right? It's the adrenaline rush. It's we get to be the first people that patients see when they come to the hospital. You get to see anything from, headache management, which could be chronic migraines, to, GSW or gunshot wounds or trauma, and stabilizing those patients. I found it during my experience in Chicago. A lot of it was certainly trauma, just because it's the nature of being in, urban Chicago. downtown Chicago, a lot of violence and trauma. But then doing some of my emergency medicine rotations outside in the more sort of rural areas, you saw trauma and stuff, but you also saw that, the sort of misuse of the emergency like the department, right? Because patients don't have access to primary care, et cetera. So they use the emergency department as their go-to. So I found that it wasn't what I maybe imagined like emergency medicine practice to be. And then I switched to something like ophthalmology, the eyeballs, right? So you're just like, wow, the eyes, but found that I was not meant for a surgical specialty, which you don't really know about until you immerse yourself in those rotations. But what I did like about both of them is that you have to have rapid decision making, especially for emergent situations, both in ophthalmology and in emergency medicine, and very strong diagnostic skills. And I think both of those are well encompassed in a field like neurology, right? I like eye movement. I like disorders of the eyes, which we see a lot of in neuro-ophthalmology, but I also like stroke care and seizure management, which are both very well, commonly seen in the emergency room. So I said, well, why not? Let's try neurology. And I actually fell in love with the field. So I proceeded to become a neurologist. Yeah.
Yeah, so to follow up on your journey, could you walk us through your decision making with which undergraduate program and medical school and residency program you chose and why you chose those programs?
Yeah, absolutely. So I think like majority of people who go through, I guess, any sort of pathway, whether it's medicine, engineering, et cetera, I don't think many people have good mentorship. At least your parents try to do, at least I can speak from my experience. My parents were, immigrants and are immigrants to this country. And their education background was in like economics and business. I didn't have anybody to mentor me in the medical field. So I did my best to what I knew was, I know this person who went to USC, Clemson, College of Charleston, whatever college you name. And they chose a specialty or they chose a major based on what they thought medical school was looking for, which is usually biology, chemistry, something, within the science field. And then when I got there, so I started off being a biochemistry major, and I said quickly, biochemistry is not for me. So I switched to microbiology, I think my second semester freshman year. Really enjoyed it, but ultimately learned that you don't have to have a science major for you to be eligible to be a competitive candidate for medical school or PA school or whatever, secondary path you choose for post-grad. As long as you're taking your prerequisites, and in fact, I think that might actually make you a better candidate for medical school because you get to actually focus, you get to enjoy the major. So if you choose psychology or I don't know, exercise science, I'm just naming some of the ones I can think of, but you can choose English. It actually makes you a unique candidate for when you apply for medical school because how many students apply as biology majors or as chemistry majors? Like how many actually apply as dance majors or English majors? It kind of helps you stand out to be, I think, a more competitive candidate for medical school. So choosing microbiology was just what I thought was the right thing to do. I think in retrospect, maybe I would have chosen sociology or psychology. I do really enjoy those fields. But I think that was for one of two reasons. One, I just thought that was the right thing to do, but also didn't have anyone to mentor me to say like, hey, it's okay to do something outside of the box of what you think medical school is looking for. In terms of medical school itself, I did apply for medical schools here on the state side. Unfortunately, was waitlisted for a few, and it's not a great feeling because you see your friends getting into, they're going to USC School of Medicine or MUSC, and that was the case for me. But I also didn't know what a gap year was at the time, so a lot of it was just not knowing the other options I had for myself. So I knew the Caribbean was a possibility. I knew that the road choosing a Caribbean school would be much more difficult in terms of matching into residency or just being an international grad. It's just a little bit more challenging to get into residency. But it was something that I knew that I wanted. It was my passion to become a physician. So it was sort of let's make the best out of what I've been given and work hard towards that goal. In terms of residency itself, I was actually, I think, it was a blessing for me to come back home and work in neurology back in Orangeburg, South Carolina, where I made the connections with the team from Columbia because they provided our tele-stroke services for us, and we worked very close with them in both USC and MUSC. And ultimately, that's how I made my connections, and that's how I matched into neurology at Prisma, at the time Palmetto. So it's all about, I think, the steps that I took to eventually get where I was. Yeah.
Yeah, no, that's definitely really amazing. I know a lot of people have different pathways to get to where they are, and it's really awesome hearing about everyone's different paths.
Yeah.
But moving on into more your specialty, can you describe your role as a vascular neurologist and how it differs from general neurology?
Yeah. So I do work as a neurohospitalist. So what that means is you have a hospitalist schedule, an internist hospital schedule. You work 7 days on clinically, and then you may be off 7 days clinically and have other administrative duties, et cetera. So the majority of my job is doing stroke, seizures, basically anything neurology. As a vascular neurologist, we do extra year, up to 2 years of fellowship training should you want to take on a position or a role as, being a telestroke neurologist where you're taking care of like acute stroke presentations. So clinically, I work mostly as a general neurologist. I take care of all conditions, right? From anything from head migraines to MS, multiple sclerosis, myasthenia gravis, epileptic patients, etc. But stroke is a lot of it. It's sort of stroke and seizures, I would say, are the bread and butter of inpatient neurology. In terms of what I do with my vascular neurology fellowship, I think you'll hear from, at least in neurology, you'll hear from the specialist that it opens up other opportunities and doors for you when you do a fellowship. So, for example, I'm the chief of neurology at our smaller sister hospital. I'm also the stroke medical director there. So I do a lot of sort of protocol and policy work in terms of how do we take care of our stroke patients there. And that's one of the few things that you could do with a fellowship training. You can either specialize it just in that, but as much as I love stroke and taking care of my stroke patients, I think I would probably be a bit bored if I only did stroke. So that's the beauty of neurology, that there's so many other things that you can treat and diagnose.
Going off of that, can you talk a little bit about what you do on a typical day? What does your day-to-day on the job look like for you?
Yeah, so the hospitalist schedule, it's 7 a.m. to 7 p.m. There's, depending on which location I'm at, the bigger hospital, I have 3 colleagues, that's including me. So there's 3 neurohospitalists, all neurologists. We have 1 or 2 APPs, they're either PAs or nurse practitioners, who also help support our team. In shifts, we cover the acute emergencies in the ED or in the hospital, and those emergencies would be code strokes. Typically, depending on if I have students, Wake Forest students, or if we have residents, which we're getting a neurology residency. We actually just matched our first class for this July, but we currently get internal medicine and psychiatry residents. So depending on learners, we round between maybe 9 and 10. We start rounds. So we pre-chart. You look at your patients, make sure you kind of know about vital signs, any new imaging, things that have been done, kind of follow up on what your plan was from the day prior. We'll round, and then more or less we're a consulting service only, so we don't admit patients. So we get consults throughout the 7 to 7. And those patient consults can come from the emergency room. They can come from patients who have already been admitted to the hospital. We also cover different hospitals and freestanding emergency rooms that don't have neurology. So we'll get consults and calls from those from like the transfer center asking for recommendations. So it's more of a stop and go throughout the day. You go see patients, you come chart, do your notes, put orders in, things like that. You might, while you're doing that, you might get a call to go see an emergency in the ED. So it just kind of depends. There's no set schedule for a hospitalist schedule, well, at least for a neurohospitalist, in terms of, because consultants, you can get consults all throughout the day. It's not kind of like, oh, you have 10 patients or 15 patients you've admitted and then you round and then you're kind of done, because we don't have a primary service.
I know you're saying that there's no set schedule for a day. Is it similar weekly? Like, does your weekly schedule differ? Do you work on certain days of the week and not work on other days? How does that work?
Yeah, so our team works Monday to Sunday. So that's our 7 on sort of, and then you're off the following week from the hospital itself. But yeah, 7 a.m. to 7 p.m. Monday through Sunday. And then, for example, this past week, I happened to work a 9-day stretch because I made some changes for going on vacation. So you just kind of switch around, but your typical schedule is 7 on, 7 days in a row. Yep.
So, kind of going off what Sanjana asked, would you prefer a more flexible schedule or a strict schedule? I know you said you moved your schedule around to do 9 days straight. Could you elaborate a little bit more on that?
Yeah, when I took this particular position, and that's a beauty of medicine, I think, as well, that you can make your schedule kind of look any way you want it to look, depending on which field or kind of setup you have. So I chose this particular job coming out of fellowship was because one, when you're, I think, first out of school, your that hunger to learn and to do is, I think, a lot stronger than as you continue throughout, right? Because things change. So I did like that I would work 7 days and then I'd have 7 days off because I do enjoy traveling. So I wouldn't have to worry about things like PTO and having to switch my schedule around a lot. So I have 7 other partners and there's 4 of us that work on each week. So it's typically if you have to, take days off more than the 7 days that you get off, we're pretty all good about switching with one another. And one of my partners is going to Spain at the end of the month and he's taking like 13 days off. But, the other week has worked with him in terms of trying to switch those extra 4 or 6 days, I would say, around throughout the weeks to make it possible for him to go. So I do enjoy it for now. I don't think it's sustainable for like a decade, but I think right now it works for me.
I know you touched on this briefly, but we mentioned earlier that you have advanced training in acute stroke care and emergency neurology. What does this exactly entail when you're doing your job? Are you just looking at emergency patients? Is there anyone that has been in your care for a while that you take care of? How does that work?
Yeah, so being in the neurohospitalist role, so we do see the acute emergencies like in the emergency room or, in the hospital that for patients who are admitted. So if anybody has an acute neurostatus change, right? So the patient's normal and they come in with facial droop, they're hemiparetic or weak on one side of their body, can't speak, etc. We see those acutely. We make a decision based on their presentation. Is this a bleed, like a hemorrhagic stroke? Is it an ischemic stroke based on presentation? So we're deciding whether they are candidates for acute intervention, like receiving a thrombolytic, which is a strong blood thinner, or going to intervention to retrieve the clot that they may have, or requiring emergent craniectomy to relieve a hematoma or a hemorrhage that they have in their brain. So decisions like that are made throughout the day. There's again, I guess unfortunately we can't tell when emergencies occur, so whenever they do. What I do like about my schedule is we split that up, the responsibility for that throughout the day. So you're not constantly on the go and you still have time to follow up on your patients. For example, if I saw a stroke today, I would still follow up on that patient tomorrow because I'm still managing and treating and attempting to determine what caused the patient to have the stroke. So that workup me seeing the patient acutely doesn't stop just there. My interaction with them does not stop there. It's basically until we finish up the workup and they have a plan in terms of disposition.
Yeah, that's awesome. So I noticed that you are a clinical assistant professor of neurology. I thought that was a very cool aspect of medicine that not a lot of people know about, where you're able to teach. Could you tell us a little bit more about why you chose to teach and how do you balance teaching with your clinical practice, and how do you approach mentoring future neurologists?
Yeah, that's a good question because when I took this role here at Atrium, we didn't have um, a neurology residency, and that won't start until this year, so it'll be more definitive in terms of the professor role. So, and I think that's because maybe I didn't see myself as a teacher going through residency and even fellowship, but in retrospect, it's actually you're a teacher from the minute you become a medical student, right? Because then you start teaching your junior medical students. Even in residency, you teach the med students, you teach your junior residents. And then when you're a fellow, you're a junior attending and you're teaching your residents and your students. And even pharmacy, like your pharmacists, everybody, they're all learning from you and you're learning from one another, to be honest. There's times when I'm at work and my second year medical student is teaching me something, that they learned about oncology that I probably haven't looked at since I graduated from residency. So I think it kind of chose me more so than me choosing it. I do enjoy it. I also say this to all my students that I love to teach when you want to learn. So I think it's getting from a mentor or a teacher is you're going to get what you kind of put into the relationship too, right? So if you're eager to learn and to be mentored, then I think the person who is in that role would be eager to spend that time and effort in wanting to mentor and teach you too.
Does the teaching position take away, do you feel like, from your time being in actual clinical practice, or how do you balance that?
Yeah, I think right now because we don't have I think if you're an academic center, I will say it this way, the schedule is such that you have time kind of built into the day to day for didactics and even informal teaching. But a lot of teaching also happens at the bedside, like at least in the hospital. There's certainly set times for didactics for at least our residents now. They between 12 to 1, they'll do like lunch and learn. Um, is just an example of how some of the formal teaching is done. But in terms of clinical, does it take away from my clinical? Maybe efficiency is a little bit different. I do maybe do notes a little bit later whenever I have learners, but it's part of, I think, the process, right? So when I was a resident and a student, the same thing happened with my attendings. It's just kind of you kind of sign up for that. But hopeful that as you put into that and you pour into that learning and the efficiency will get better because your students and your residents will start to pick up on things that hopefully that you're teaching them, that it may make rounds go a little bit faster, things like that. So I think it's not a bad thing.
Got it. On a different note, looking back at your journey, what's one piece of non-medical advice that you would give to pre-med students who want to follow in the same path?
Huh. I think I give you a lot of advice there, but in terms of non-medical, I would say have fun. Have fun in college, whatever that might look like for you. Immerse yourself in activities that don't, they don't have to be within the medical field. They don't have to be volunteering at the hospital. Like certainly do things like that because it does help you build your CV to be, a candidate for medical school, but do things that you really enjoy and that you're genuinely interested in. Don't just fill your CV with fluff just to make it seem like you did a lot of things, but spend time doing a few things that you really enjoy doing that have a purpose to you, because that shines through when you go for your interviews or when you are just talking to, you want to be more than just, Sanjana, I was a biology major and I was in a medical fraternity and that's all I did. But I want to be like, well, what else did you do? Like, did you take dance classes? Were you on a dance team? Something, that makes it unique, that shows that you also have interests outside of just medicine. And I just chose you because you were asking me the question. So
No, no, no. I just laughed because I am on a dance team and I saw that you were interested in dancing and I thought about that before hosting the webinar.
yeah, that's just an example. Like, yeah, just something that you generally do enjoy doing. And you can do both, but it doesn't have to be just all down the medical track. I think that's a big misconception. I think that a lot of students have.
This is a very similar question, but in your experience, what areas do you think pre-med students should focus on, and what is also not worth stressing over?
Could you be more specific in terms of what, like, in terms of, do you mean just like areas in school or just in terms of focusing on like,
I'd say just kind of like what you were saying before, whether it's extracurriculars, doing what you think is fun, being able to balance everything, and just Does that make sense?
Yeah,
Or
Or
I
even
think
just with like research, gap years, things like that, what would you recommend putting more emphasis on?
I think research, at least from what I've been told, and mind you, it's been almost a decade since I graduated medical school, so it looks certainly different now in terms of what makes you what requirements I think med schools are looking for. But from what I've been told by at least the generation of and the newer medical students that we've been rotating with, I think there's been a little bit more focus on having some research. But I think that's more so for when you're a medical student coming into residency. I think that's probably where it's where that kind of comes from and stems from. I don't think when you're in college, I don't know that having a in-depth and sort of profound research background is going to make you a better candidate or not, unless you are applying for like an MD PhD program, or you do want to end up doing research, at an Ivy League or something. So I think it kind of gets tailored to what your goals are. If you do want to end up in a research or like a dual program, I think certainly um, make that a goal to do research so that you can shine through in that applicant pool. But other than that, I think just work on developing good, interpersonal skills, which is very important. Being a physician, learning how to balance a lot of different activities, and because when you're a medical student, you'll have time for, well, I would hope that you would have time for doing fun things and enjoying time with your friends and family. But how do you do that and still succeed through medical school? I think just building on skill sets that will make you able to do that. I think that just focusing on things like that more so than particulars of what you need to do for med school.
to follow up on that, as a professor and seeing residents and medical students come in, what has been the biggest characteristic that really makes someone stand out?
Yeah. Um, I think the willingness to learn. I keep going back to that because I think we often get so caught up in um, what we, I guess, what we don't know, or maybe making excuses for, well, I didn't do this because I don't, as a professor myself now, I'm not so much interested in what you don't know, but do you care to learn to know, right? Like that's what I'm interested in is, are you eager to learn? Do you want to find out why? If I ask you a question, I think I get pretty irritated when they say I don't know. And that's okay, but I want it to be like, I don't know, but I'll find out. Like I'll read into it and let's talk about it tomorrow. And I think an attending or any professor asks you a question, it's never to be malicious or to embarrass you. And I think again, having been a student and then a medical student and a resident and then a fellow, I think on that side of the table, it was also always like, well, oh my God, I'm be embarrassed if I don't know. Um, Matter of fact, I think more times than not, I sometimes don't know the answer either. So I want you to find out so we can both learn, right? So I think that certainly stands out in some of my students, the ones that are really they go read on it and then we talk about it the next day, and it's a learning point for all of us. Yeah.
That's super helpful. Thank you. And that there's a question in the chat. You mentioned serving as both a chief and a director. Can you explain what those roles involve and how they influence your ability to balance responsibilities while also caring for patients?
Yeah. I think I'm still learning to balance all of it and to not be stressed out all the time. But I think that's the nature of, I guess, being in any profession. So clinically, I have my responsibilities of seeing my patients, coming up with neurological plans of care, and making sure that they all have good outcomes. From a director role, I'm the stroke medical director, so I work alongside my stroke coordinators and our stroke team to come up with seamless processes, both in the emergency room setting, but also on the inpatient setting, right? Because when I refer to the inpatient setting, these are the patients that have gone through the emergency already and now are admitted to the hospital. And acute emergencies can occur anywhere in the hospital, not just in the emergency room. So right now, for example, I was in the last 9 days, I was at the hospital where I served on the administrative boards, and it was rather challenging because I was being pulled in multiple directions. Clinically, I am there for my patients, but I was also there as an administrator, making sure I was there present and helping with these policy changes. So it was there were very long days, I will say, but I think learning how to set boundaries and making those boundaries clear. It's right now, what is my priority? My priority is taking care of my patient. This is what my clinical priority is. The policy changes are just as important, but they're not acute. They're not something that need my attention at this moment. So those are the things that I would put on the back burner and maybe do when I had a lighter day at work clinically. In terms of the difference between a director and a chief, so the directorship is specific to just stroke medicine or stroke neurology there. So making policy changes to that. The chief role is doing a little bit more, I would say. I'm going to make it sound more simple than it is, but it's more or less paperwork and helping with helping the system or the hospital itself kind of go through credentialing processes for the other physicians and APPs that sit under the neurology and psychiatry umbrella, because the American Board of Neurology, it's psychiatry and neurology together. So helping with the credentialing process for new or onboarding physicians, APPs, making any other sort of system-wide changes to our neurology services. So that's how they kind of differ. They have overlap because the chief of neurology also kind of, obviously they're over the medical director, but I kind of do both.
And I'm sure, like you were saying, juggling all these responsibilities gets exhausting. And within the healthcare field in general, now is such a big, prominent issue that we do see. How would you recommend, or do you feel like you balance your time, your mental health, and personal growth and development?
Yeah, that's a great question because we talk about mental health all the time with our patients, but well, how do we juggle with it and how do we deal with it? Um, I think I've been better about it over the last 3 years, at least being a fellow and a resident. It's different. I don't know if this is a Gen Z term or a millennial. I actually don't know, but trauma bonding, right? I see that all stamped all over social media, things like that. But I think in residency and fellowship, you just kind of trauma bond with your co-residents and your co-fellows. You talk about your tough days, and although your family and friends can empathize with you, they can't sympathize because they haven't gone through what you're going through, right? So that's kind of what we did in fellowship and in residency. As an attending, I think I've come up with more healthier ways too than other than to trauma bond. So exercising is very important to me. I try to be as active as I can, even if it is just going for a walk after work, especially with the weather being nicer. We know that sun therapy is the best therapy, in my opinion. But so making time for healthy habits, so exercise being one of them. There's so many other things. I mean, I have colleagues and friends that do a lot of journaling, and this might be taboo to talk about for some people, but therapy also works. I think we all actually would benefit from going to therapy, whether you're a physician or whatever field you're in. So therapy is more and more talked about now openly. I think there was always sort of a negative stigma towards that, but absolutely nothing wrong with therapy there. And we have 2 family dogs, so I think my dogs help us. So
Thank you so much. That was super insightful. And as someone who has a dog myself,
yeah,
very, very comforting, very, very good stress reliever.
absolutely.
Um, with that being said, we will continue questions after the case study, but are you ready to move on to the case study portion?
Yeah, let's
Okay.
do it.
Okay, well, I don't know why the title isn't here, but
That's okay. We're just gonna go through some vascular case conferences. We can go to the next slide.
sorry, give me 1 second.
Okay,
I'm just gonna stop sharing and then start sharing it again. We'll see if that helps.
sure. Do you want me to try sharing it from my computer? Would that help maybe?
Yeah, or if Sham, if you have it pulled up and if you think you can share.
Yeah, I do have it on my PowerPoint slide, so I can pull it up here.
Perfect. Sorry about that.
It's okay. Right. Can you all see the screen?
Yes, we can.
Right. See, it's not pulling up for me either, so I don't know what it is, but maybe I can just leave it on this screen here and we won't do the PowerPoint presentation mode.
Yeah, that's probably fine.
Okay. So just to go through some basics of neurology, and I won't get into too many details, but hopefully maybe I'll see one of you or all of you as my students rotating with me one day in the future. But this is basically a non-contrasted CT. So what do I mean by that? We don't give the patient IV contrast. So when you're looking at a CT scan of the brain or the head, this is an axial view. That's basically the version or the slicing of the CT you see here. And on a non-contrast CT, the things that are bright when I'm pointing to here, this area here, and then around here, which is a skull, I refer to them as the 3Bs, or that's common in neurology to refer them as the 3Bs. It's going to be blood, bone, or bullet. And when we say bullet, anything that's metal is going to show up bright or hyper dense. When we refer to CT scans, we talk about density of the brain tissue. So here in the first scan over to the left, you can see that there's hyperdensity in this sort of concave shape, and this is an epidural hematoma. Here you see a hyperdensity within the parenchyma of the brain tissue, because what we're looking for, I should say, basics of a CT scan, we look at an axial view. You're looking for symmetry on both sides. So very obvious that there's this area that's not the same, right here and here. And so this is also hemorrhage, a hyperdensity on the right side because it's opposite of what we are looking at. So this would be the left side of the brain. This is the right side of the brain. So a hyperdensity here. And then this obviously is this is the skull. And so bone is going to be bright. Blood is going to be bright. The dark areas here, those are the ventricles. That's where your CSF or your cerebrospinal fluid is kind of goes through, is also made in different parts of the ventricles. And the scan over here to your right, I think it's just pointing to some structures that you would commonly, be able to identify on a CT scan. The same structures here that look like little hockey sticks. Those are your ventricles, your lateral ventricles, and that would be your anterior or your frontal horn of the ventricles. This is referring to the Sylvian cistern. This is the third ventricle here in the middle. And then this is part of the cerebellum, which is the back part of your brain, which for majority, I guess for simplicity's sake, we could say helps with your coordination, your gait. Any questions on these three before I move forward?
Yes. What would you say the most common causes of hemorrhage in the brain is?
Yeah, so for something like this, the first scan here to the left, the epidural, we typically see this in someone who has had some sort of head injury or trauma. To the two types that we see from the types of hemorrhages like this are either epidural hemorrhage, that would be more concave like this, or a subdural, which is usually convex and kind of sits along like in a banana shape along the side between the dura space and the brain. Those are both due to trauma, and depending on usually age, things like that. So subdural hematomas we'll typically see in like an elderly population or a patient who's had a pretty significant trauma to the head. The epidural hematomas, I don't know if this patient fell and like hit their head. Sometimes like if they got struck in the head with an object, that can lead to an epidural hematoma. This hematoma here, the hemorrhage here, if I had to guess, because it's in the subcortical space, meaning that it's not along the cortex or the outer part of the brain, this is probably and based on where the location is, probably from hypertension. So uncontrolled hypertension or hypertensive emergency is probably what causes kind of bleed here. Does that answer your question?
Yes, yes, it does. And kind of to add on more to that, I know we see a lot of head trauma with football players. Could you talk a little bit more about that? If
Yeah. So I would say the majority, and I don't see a lot of these patients. I actually do volunteer with on the concussion team for our Mecklenburg high school teams. So the majority of the trauma that we would see with football players is going to be like concussions. We don't typically see these types of hemorrhages, so the epidurals and the sort of intraparenchymal hemorrhages with like athlete concussions. Sometimes you can see contusions, which would also be along the cortex of the brain here. But typically in athletes and football players, we're not seeing a lot of damage. And from a CT scan, you don't see a lot of damage on the CT. Now, over time, with repeat concussions and depending on how bad the injury was, we can see evidence of brain trauma on an MRI scan. And rarely you could see stuff on the CT too, depending on the severity of the trauma. Should I move on to the next slide? Yep. Okay. So case one, and I'll just kind of give us a brief overview of it. So this is a patient that came in acutely in the emergency room, had twitching to the left side of the face. They had slurred speech, which we refer to as dysarthria in the neurology world, and they were confused over the last 12 hours. Spontaneous resolution of the symptoms, history of a recent polypectomy in the colon. It was benign, otherwise healthy. So in terms of what symptoms as a presentation or the person presenting with, we know that they've had facial twitching. They've had some transient slurred speech, transient, meaning it came and went. They had some confusion, and there's no deficits or nothing in terms of their neurological exam when they are being evaluated. So just to go through some basics of the facial twitching. Now, if you're looking at the CT scan here, you can see that there is, and actually this is an MRI scan from what I can tell. Yeah. So there is this lesion here on the right side of the brain, here and here. There's some enhancement, meaning that there's contrast pickup by it. And for the majority of the brain, apart from the cerebellum, if you're in the cerebral hemispheres, the offending agent, or here the lesion on the right side, would cause symptoms on the left side of the body. So the patient came in with left-sided facial twitching. This is probably the reason why, or is the reason why, I should say. And the facial twitching, as you can see here, was probably a focal motor seizure. The dysarthria and the confusion, again, probably from the patient seizing. When we talk about localization of lesions and what part of the brain controls what function of the body, this being on the right side of the brain certainly doesn't always cause aphasia, although you can have something called like speech apraxia, and these are more technical terms that we can get into at a later time if needed. But I wouldn't typically see aphasia from a right frontal lesion. It would usually come from the left side, but certainly could have that in a small percentage of population of patients whose language centers sit on the right hemisphere instead of the left hemisphere. So the workup for a patient like this, where I'm suspecting this is a tumor, which this looks very much like it, the workup would be to one, figure out if they have a primary source or a primary malignancy, right? So you can see here on the workup and diagnosis, the patient's had a CT scan of the chest, the abdomen, and the pelvis to make sure there is no primary tumor, whether it's colon cancer, especially given the history of the colon polyps. And then the MRI, when we get an MRI, it's more specific and sensitive test to help give us more details in terms of what is the tumor or the area of this lesion. What does it look like? Does it enhance with contrast? Does it enhance all the way, or is it there heterogeneous enhancement or homogeneous enhancement? That gives us a little bit of details on what our suspicion is. Ultimately, for lesions like this, it looks very much like a glioblastoma, but that's obviously from trained eyes. If this is something that we see in the emergency room or even on inpatient workup, we would still consult our neurosurgery colleagues who would ultimately do a biopsy to confirm through histopathology what type of tumor this is. And it seems like this patient had a GBM or a glioblastoma multiforme, so a grade 4 astrocytoma. The motor mapping is done by neurosurgery colleagues, so they can do this MRI and actually in real time to help determine which pathway, and again, if they're resecting or removing this tumor, what's going to be affected, and to basically avoid having the patient have a bad outcome, especially given that they're otherwise, neuro intact. So just a quick overview, a craniotomy to then remove or resect the tumor, and then the patient usually will go discharge home and follow up with a neuro-oncologist who will start them on treatment. Now with GBMs, I'll say the overall prognosis isn't always great. I've had patients who have, lived a few months after GBM, and then others that have been okay for several years. The thing with GBMs or glioblastomas is that they do recur oftentimes, and depending on where the tumor is, they can be resected again, but that would be a case-by-case basis. Any questions before I move to the next slide or the next case?
Yeah, I had a quick question. You said that this looked more like an MRI when you looked at it. What are the key differences? How can you tell
Yeah.
what is MRIs versus CT scan, and when do you use one versus the other?
Yeah, good question. So what kind of gave it away is, do you see like the extinction between the gray and white matter here in figure A, and then the enhancement here and here? So these are in the MRI scan, you get different series. So you get, for example, T1 with contrast, T2 with contrast, flare. These are just different series that I'm kind of naming. And again, just because based on trained eyes, I can tell that this is an MRI scan there. Although sometimes it's difficult to, because the CT scan, for example, here, if you just look at a cut of the CT scan with contrast, it can look very similar to even this scan here. But because there is a side-by-side, I could tell that one's a, T1 with contrast, and the other probably also just a different version of it. The CT scan, the non-con CT, we get, that's the first scan that you get. It's quick. It's in terms of cost and things like that, it's also less costly than an MRI, but it's the first scan that we get when the patient comes into the emergency room, just because it's so quick. It just gives you a quick idea and answer. Is there a hemorrhage? Is there a bleed? Is there anything that we need to act on, immediately? For the purposes of like stroke care, we obtain that first to make sure there's not a bleed. If we are thinking about giving a patient like a blood thinner or something like that for a suspected ischemic stroke, which is a type of stroke that's due to the lack of blood flow to a certain area. So that's what the CT scan would be most useful for. It can still show us, areas of hypodensity, or this probably showed up on a CT scan and just looked very dark. Let me see if here example. So instead of it looking like this, it would have just been very dark. It wouldn't have been this bright, and it would have had a lot of edema. So a lot of this would have been a lot darker on the outside. Versus an MRI, you can see edema and swelling around it, but it would be on a different sequence of the MRI scanner. So it's a MRI without contrast takes about, I would say 30 to 45 minutes. And then a contrasted MRI usually takes about an hour long plus. So it just takes a little bit longer than a CT scan. When I say little, actually, probably more than 45 minutes. A CT scan takes maybe 10 to 15 minutes to get. Okay. All right, so then case 2. So this patient came in with a severe sudden headache. Initial blood pressure was 200 over 110, and we know, normally blood pressure is about 120 over 80, 130 over 90, depending on which literature you read. Patient didn't have any neuro findings on their initial exam. They got discharged. They came back with worsening symptoms. Now they have a persistent worsening headache. They have a pronator drift, which just means if you have your arms out and the patient's kind of doing this kind of drift with their left arm. It seems like they had a 6 weeks ago, they had a car accident, which they did not tell the ED provider on initial presentation. If you look at figure A here, and this is going to be more subtle. So I remember I told you on the first slide that anything bright is going to be either blood, bone, or bullet. You can tell that here's the skull, which is the bone. But if you look to the right of the patient, but the left for our imaging purposes, you can see here there is this sort of convex difference between the brain tissue here and between there and the skull. There's also some here along the left frontal region here, and that's a subdural hematoma. So it's between, again, the dura mater and the brain tissue. It can push the brain tissue. And unlike other parts of the body, the brain is within an enclosed cavity, the skull, right? So there's nowhere for the brain tissue to go apart from midline, and then it goes down. It can cause herniation and pretty devastating symptoms or sudden death sometimes. So subdurals are due to bridging, like basically bleeding from the bridging veins between, the dura mater and the brain. I typically see this kind of presentation in terms of the headache. Initially, the CT scans are negative. You can certainly have it in subdurals, but I also see it in epidurals. So patients who have, especially athletes, you'll often hear maybe, I would say probably more or less on TV shows or something, when someone has a pretty devastating head injury, but their scans are negative, they get discharged, and then you hear the physicians or someone telling them someone make sure you're keeping an eye on the patient or on the person. Don't, if they're sleeping, you want to make sure that they awaken easily and that they're neuro intact. And that's because epidurals and subdurals have this, more so I would say epidurals have this classic of they can have a pretty normal scan initially, and then you have this kind of rebound headache, and they have worsening acutely, and they can cause pretty devastating outcomes. So this is, again, a subdural hematoma here and here. And it looks like they might have had it evacuated. So this little dark area you see between the bone and the brain tissue, we call it pneumocephalus, meaning that there's air within the skull cavity or in the skull, and that's probably from having this evacuated by a burr hole, which is when the neurosurgeon takes, literally looks like almost like a drill, I would say, and they do a burr hole through the skull cavity to evacuate that hematoma or that blood, so it doesn't continue to push against the brain tissue, causing neurological deficits. Okay. Any questions on this before we move forward?
Yeah, I had one quick question. I know with some head trauma, the patient isn't supposed to go to sleep. Could you elaborate a little bit more on that and explain why that's an issue?
Yeah, so that's what I was referring to with the epidural hematomas, or even subdurals. I guess in this patient's case, they had initial scans that were normal. And I don't know that I've ever told a patient not to go to sleep. Maybe it's more so having someone to monitor them and make sure that they maybe have them wake the person up every so often to make sure that they're neuro intact and that they don't have any deficits. And that's because of this reason. So initially you might not see that area of blood building up, and then as it continues to get larger, that hematoma or that hemorrhage continues to get larger, that's when they become symptomatic. So it's just to make sure that their neuro assessment is being closely monitored. Okay. Right. Case 3. So this patient had sudden onset of left-sided hemiparesis, so weak on the left side of their body, probably including their face. Upon waking from anesthesia, they just had a total knee replacement, and they have a known meningioma, and they also have an ICD, or implantable defibrillator. So the symptoms, again, this is acute, meaning all of a sudden left-sided weakness, no prior symptoms from before the surgery. Hopefully between the surgery and post-op, they didn't have any signs or no trauma or any other signs of stroke. So on the CT scan that they obtained, and I think, Sanjana, maybe you asked a question. So you can tell that with the contrast, it can kind of sometimes look similar to an MRI scan, the CT scan, but certain factors on the scans can kind of help you differentiate between the two. So this patient couldn't get an MRI, it seems like, because they had the ICD. It's usually the wires that are associated with the defibrillator make it MRI incompatible. So they see this mass here, which is the hypodensity I was referring to on the first. There's hyperdensity, which is usually blood, bone, or bullet. And then hypodensity usually refers to that there's either new stroke, like an ischemic stroke due to blood loss, or there's a mass with a lot of swelling around it. You can't really tell on a CT what it is, depending on if it's in a vascular territory or associated sort of factors. You can kind of have a educated guess as to what it is, which is usually confirmed on an MRI. But here you see that there's this area of hypodensity in basically the right frontal sort of ACA, MCA territory here. And then here with contrast, you can see that it's a new enhancement along that mass there and some edema. Meningiomas is a type of typically benign brain tumor. They usually don't really cause any devastating or any neurological deficits unless they are large like this one and have a lot of swelling around them. But typically they're small dural based tumors that, again, don't have any significant symptoms. So here the patient ended up having symptoms due to all the sort of edema and the swelling that's surrounding the small meningioma, which is this homogeneously enhancing tumor along basically where you see the skull. So in terms of why the patient got dexamethasone, it's a type of steroid. We usually give that when patients have intracranial tumors, and it helps with the swelling. In this case, it didn't help with the swelling, and the patient continued to have swelling, causing them to have symptoms. Do you see here the ventricles? You see how one side is a little bit more open? You can see it. If I move my cursor here, you can see that it's open almost. But on this side, it looks a bit compressed. It looks like it's slit-like, that dark area there. And that's what we're referring to with mass effect or pressure. Ultimately, the patient also had a craniotomy, and they removed the meningioma, and that will eventually help with the swelling going down in that area, and the patient will hopefully have some improvement in their strength.
Can you briefly explain what an implantable defibrillator is?
Yeah, that's typically for our patients who, like an ICD, so patients who have cardiac arrhythmias or have had trouble with, bradycardia, so their heart rate's too low that they keep syncopizing, like they pass out, as in comparison to someone who has bradycardia because they're a lifelong athlete, like, professional football players or runners, et cetera. They're going to have a resting heart rate that's lower than the general population because they've been kind of used to it, the sort of gradients throughout their lives. But the ICDs are typically for patients who have had some sort of cardiac outcome or complication because they have an arrhythmia. So it's there to basically provide, I wouldn't say shocks, but it kind of does. If it detects that you're going into an arrhythmia, it can kind of reset you. But it's not nearly as great as obviously, having like hospital kind of served defibrillation. So, but it's there to help monitor those arrhythmias and to kind of help you come out of it.
Would you say it's very similar to a pacemaker?
Yeah. Okay. Okay, to move to the next slide. All right. So what does a stroke look like? I think for the general population, things that, we teach, the warning signs are through FAST, which is an acronym that stands for, facial asymmetry or facial droop, arm weakness, speech difficulty. And speech difficulties can mean slurred speech or the inability to produce, sensible speech or to understand speech. And then T is, calling 911. So we talk about time is brain. Every minute that you lose blood flow to a part of the brain tissue is over almost 2 million like neurons lost. Other symptoms that you can, see depending on which part of the brain tissue is affected, you can have unilateral numbness, you can appear confused or are confused, you can lose different visual fields and have visual field deficits, you can have trouble with ambulating, And then headache is very common in strokes. Doesn't matter what kind of stroke you have, but majority of my patients present with some headache along with having a focal neurological deficit. So the causes or what types of strokes there are. There's ischemic stroke, which is due to a blockage of an artery. So you can have a ruptured clot that comes from either having really bad carotid disease, from a long-standing history of having high blood pressure, diabetes, all that kind of plaque, cholesterol, being a smoker, using tobacco, things like that. That plaque kind of builds up within your aortic arch or your carotids, and it can rupture and cause you to have a stroke because there's an artery blocked. You can have atrial fibrillation or some sort of cardiac arrhythmia that allows clot formation to go from embolize from your heart into your brain and causes that artery to be blocked. So those are ischemic strokes. And for those is what I was referring to. We use TNK or TPA, which is a strong blood thinner, or if they're not a candidate for that, our neurointerventionalists go in and try to remove the clot depending on where the clot is, if they're a candidate. The other type of stroke is a hemorrhagic stroke, which is what we saw on this first slide here. This would be a hemorrhagic stroke here from at least what it appears to be initially, probably a hypertensive hemorrhagic stroke. And those are usually due to ruptured blood vessels, typically from just friable vessels over time because you have uncontrolled hypertension, what we call sort of lipohyalinosis of those vessels. And then you can also have a subarachnoid hemorrhage, which is also a type of stroke, which is due to like you can have an aneurysmal subarachnoid or a non-aneurysmal subarachnoid, but that's due to blood within the subarachnoid space, not within the brain tissue itself. So the major three types of strokes there. And those all present, hemorrhagic and ischemic strokes present pretty similarly. One's just due to the lack of blood flow. The other one, you have a ruptured vessel. And then subarachnoid hemorrhages typically present with, most patients will have this sort of severe headache. They kind of describe it as like the worst headache of their lives. It's sort of like a thunderclap, like a big headache that they get. It doesn't go away with medications. And again, all three of them are emergencies and all are managed very differently. The hematoma or the hemorrhage that we talked about, so a subdural, right? This is a prettier, or I guess a better picture of the subdural than the one from before. But again, between the dura and the brain tissue, I kind of treat these the same, a hematoma or hemorrhage. The hemorrhage with the ongoing bleeding, if there's worsening of this bleed, and again, this is probably something that would go to neurosurgery pretty soon to get evacuated, just to make sure that there isn't any devastating or worsening neurological symptoms. But any of these things can occur when you have a hematoma or a stroke, right? You can have seizures, you can have vision or hearing loss. It just kind of depends on the presentation and where the hematoma is. Going to sort of, well, what do we do for stroke care for our patients, and what are some of the, I guess, medical challenges that we come across for our patients? And I think the next 2 or 3 slides is more or less going over the availability of care for our stroke patients and just in general neurology between like an urban area versus a rural area. So again, in an urban, I guess, setting, you're going to have a little bit more access, actually significantly more access to specialists just in general, whether it's a neurologist, a neurosurgeon, or a hematologist or oncologist. It's just there are going to be more providers and more specialists because of many reasons. It's bigger cities, bigger centers have more resources for that. There's more scan availability. There's, in terms of education and the availability of having multiple sort of tiers of people in-house versus smaller areas is going to be better in urban centers. I think it all goes back to resources and money, right? And what's available in these bigger centers versus in rural areas. That certainly makes the stroke care and just care in general a lot different than our rural areas. So going back to the same thing, my hometown, I would say, is more rural. So we don't have a comprehensive stroke center. We're actually a primary stroke center. And in fact, we don't have a neurologist in-house 24/7. So a lot of these hospitals rely on teleneurology. So telestrokes, I guess, neurologists who, you press a button on a computer in the emergency room. They do their best to do a neurological exam with the help of the ED providers and nursing staff on the other side. And they make their decision based on that evaluation, whether the patient needs acute intervention. And then, so they provide that acute intervention. And the only intervention that you can really provide at a primary stroke center is, blood pressure management, things like that, of course. But from a stroke perspective, giving the thrombolytic is usually one of the things. And then we call it drip and ship. So you start the drip of the medication and then you transfer the patient acutely, whether it's via helicopter or, ALS ambulance to the closest comprehensive stroke center where they can continue for whether they need neurointervention or neurosurgery for further evaluation and management. And if they're at a bigger center, there have been studies that show that access to post-stroke care and recovery is better, just because, again, it all goes down to resources available. And of course, these are the smaller areas, and unfortunately, because we all know that rural communities, due to resources, also don't have the best medical literacy as well. So we see a lot of what we call like food deserts, and where there's not a lot of available fresh foods and healthy low sodium foods, the things that cause vascular risk factors like hypertension and diabetes, obesity, end-stage renal disease, right? All these things. So a lot of it goes back to medical literacy and having the resources to be able to decrease the risk of having vascular outcomes. Any questions on those two or sort of that before I move on?
Do you have a probable solution as to how we could potentially bring more resources to rural communities?
I wish I had the perfect answer for that, but there's always ongoing work in terms of availability from a provider standpoint. I know South Carolina, for example, at least a few years ago when I was still in training, was offering incentives to have like neurology availability in a lot of these kind of areas where specialists aren't readily available. There's also a lot of grants, et cetera, that are being, that are out there in terms of building sort of resource areas, whether it be for food, et cetera, and for education too. So if you educate a patient or a person in terms of, well, these are the things that you can do to help minimize your risk of being a diabetic or having hypertension, then I think that itself is more valuable than only giving out the appropriate food or the care. Of course, it's a system-wide initiative, and I know there's several different sort of pathways that are being taken to help with this. I just don't know that there's only one answer. I think it has to be kind of approached from multiple different areas, education being one of them. Oh. And I kind of probably already went through some of this just in our talking about rural and urban kind of areas, but socioeconomic status, as we know, just in general, whether it comes to getting neurological care, but even if we just talk about education, right? All of you are in college right now, or college students, but I'm sure depending on where you grew up and things like that, not everybody in your class looked the same or came from a similar background as you did. So socioeconomic status kind of ties into the when we talk about social determinants of health and neurology. Similar, it's what is your medical literacy and how much do you know about what what risk factors you have, and what access do you have to, good nutritious food, the information, healthcare, things like that. And I think that kind of trickles down into the rest of these numbered sort of determinants is education, health literacy, what kind of environment are you in, what access do you have, are you supported, are you isolated in terms of when we talk about mental health. That has a lot to do with our patients who, develop neurocognitive and neurodegenerative diseases, not only just stroke, but just, long-standing sort of histories is do you have the support from your family, or do you have certain nursing homes or sort of Alzheimer's homes in your community that can help support this? So it goes back to a lot of different things when we talk about just care in general, not even in neurology, but just in any parts of medicine. And I wanted to actually mention this here when we talk about food insecurity and nutrition. I just like that vitamin B12 was mentioned, because we think it's just vitamin B12, but it's actually one of those or I would say vitamins that won't harm you from taking daily, right? In fact, it'll actually help you. And I see so often our patients come in and they're scared to take vitamins because you can be toxic from certain vitamins, but vitamin B12, not so much. And in fact, we see a lot of pseudodementia from patients who are vitamin B12 deficient. But just a kind reminder to take your vitamin B12. So I think that's all I had from the slides there. And I don't think I've actually ever seen a hemorrhage in this shape, but I thought it was pretty cool to have a question mark in the brain tissue there. So any questions?
Well, that was amazing. Thank you so much for going through the presentation and talking through some common cases with us as well. If anyone has any questions, please feel free you can either unmute or just put them in the chat and we can answer those last couple questions. With that being said, is there anything else that you'd like to add, Dr. Patel, knowing that most of us attendees are pre-med students looking to hopefully go along somewhat of a similar path to what you've taken on?
No, I think I do want to stress that do have fun during this process, right? You go through college and then you blink and you're a resident, and then before you know it, you're an attending. So try to make the best of your interactions with one another and, having a good experience during your college years. And again, the gap year thing I want to kind of talk about again is if you have to take a gap year, I don't think there's anything wrong with that. You get to travel, because once you're in a field of like medicine, it's going to be very difficult to take time off to, it's not like most medical professionals don't have jobs where you can just take a month off and, go travel the world, et cetera. So if you have certain passions and things that you want to give time to, it's okay to do that. It's okay to change your mind and take a different path, but ultimately still end up at the same place, right, that you want to get to. So I would say don't be scared of changing your mind, and don't be scared of failure, and because you're going to get up and you're going to continue along the same path. It's just going to look different than the path that you envisioned for yourself or that your friend or your colleague has. So what questions can I answer for you, if any?
I mean, I have just a chill question. What would you say the craziest case you've seen throughout residency and becoming an attending?
The craziest, honestly, I think every day we see pretty interesting cases. I joke, but it's not meant to be like funny joke. But if there's something interesting or crazy to a neurologist, it's probably bad for the patient. So most recently, I mean, we get to see ALS, like diagnoses, probably once every few months. That's the most recent sort of like, wow, it's ALS, but unfortunate for the patient because there's no cure for ALS. I don't know if anything like wow, because I think everything's wow in my mind. But yeah, that's the most recent case I can think of is like ALS. We see seizures all the time, different types of seizures. We certainly, a lot of those things are, yeah, wow, that the patient has a true pathology, but I don't know. I think maybe it doesn't seem as cool as it once was. Yeah.
Are there like certain cases that you're particularly most excited to, I don't know, when you see someone come in with something?
Oh, wait, I actually lied to you, not the ALS. Have you heard of NMDA encephalitis?
Mm-mm.
Okay, have any of you heard of the book or I think it was on TV or on Netflix. It was called Brain on Fire. It was a movie. Maybe, maybe not. Okay.
I'm not.
So maybe look into it. I would recommend reading the book over the movie. But NMDA encephalitis, it's a basically it can cause a limbic encephalitis it can cause seizures, it can cause agitation, psychosis, hallucinations, and it's due to this receptor antibody, NMDA, that gets basically produced typically in women ovarian teratomas. So they have this teratomas, which is a type of tumor that grows within their ovaries, and it basically produces this receptor antibody that circulates, and it causes these um, again symptoms, and usually, like I said, agitation, sort of personality disorder, and it happens pretty acutely. I would say subacutely, meaning over a few weeks. So this most recent patient we saw, she's 18, and her parents brought her to the hospital because she was not acting like herself. She was making up stories, inappropriately laughing, making jokes that were inappropriate, things like that. And it turns out and she started having seizures, but turns out she had NMD encephalitis. So that was actually the most recent case. So yeah, I think stroke and seizures are, to answer your question, Sanjana, are always like the sort of the easy ones that we see, but it's the ones that are more challenging to diagnose or that are the ones that are my favorite because I actually get to practice and think about all the things that I don't get to see on a daily basis.
For sure. Well, if there's no other questions from any of the attendees, we can go ahead and start wrapping up. Thank you so much again, Dr. Patel, for being here and sharing your experiences with us. And thank you to everyone who joined us even during mid-final season. I know it's a hectic time, but thank you for joining the conversation. If you have any additional questions that you weren't able to ask today, you can always go to our website and put it in the question spot on there, and we'll get them answered by Dr. Patel. And again, like we said before, a recording of this webinar will be on YouTube and a podcast will be uploaded shortly. And feel free to reach out to Sai, myself, Sham. You can always refer to the contact page on our website. And on that note, thank you so much for being here. Thank you, Dr. Patel, once again, and we hope you all have a good night.